Hello everyone, this is Chadi Alraies coming to you from SIF 2026. I'm privileged to be with Dr. Gregg Stone to talk about what's new and what is the most kind of update in the mitral valve transcatheter intervention. Dr. Stone, always privileged to be with you.
Thanks, Chad. Pleasure to be here.
Yeah. So mitral valve,
Yes.
functional versus degenerative, but you gave a great presentation about that. So can you give us an overview of the issue and what we have now as a therapy?
Sure. Well, the real new data that we have from the last several years is treatment of functional mitral regurgitation. That is, MR that occurs during heart failure, secondary to left ventricular dilatation in most cases, occasionally due to atrial functional mitral regurgitation with a dilated annulus from left atrial myopathy.
Right.
So, as you know, we have 3 randomized trials in which we've got good guidance as to which patients might receive benefit. And we have new guidelines that have came out at the late 2025 last year from the European Society of Cardiology and EACTS, which I think are pretty much on target. And they now give a class 1 indication for the use of transcatheter edge-to-edge repair, that is mitral TEER, in select patients with severe ventricular functional mitral regurgitation. And you have to use the United States American Society of Echocardiography criteria, multi-parametric manner to determine when you've got severe MR. And it's usually an EROA of greater than 0.3 or pulmonary systolic venous flow reversal, et cetera. And there's specific conditions though, and it's pretty much they've given the guidance according to the COAP criteria. So a left ventricular ejection fraction 20 to 50%. In patients who are still symptomatic despite maximally tolerated guideline-directed medical therapy, without marked left ventricular dilatation, without marked pulmonary hypertension or severe right ventricular dysfunction. And so that's class 1 in the guidelines. And we know from COAP that those types of patients have reduced heart failure hospitalizations, mortality, improved quality of life, et cetera. They also afford Class 2B indications in situations where we don't have randomized data yet, and that would be severe ventricular FMR of other conditions. So for example, cardiogenic shock, or NYHA Class 4B, bedridden end-stage patients, or atrial functional mitral regurgitation. And we have registries suggesting that TEER can benefit all those patients, but we really need more randomized data before they elevate to class 1.
But as you said, the second cohort is very hard to randomize because, as you said, if they're too sick to go to a trial, enrollment would be challenging.
It is, but there is one trial ongoing of cardiogenic shock patients called Capital Minos that's been going on for a number of years in cardiogenic shock with severe mitral regurgitation. And we're also starting a randomized trial in patients with atrial functional mitral regurgitation on 400 patients in China. So these trials can be done, but they're definitely harder. Then one of the most exciting new emerging concepts is treating earlier. Because even if we treat severe functional MR and chronic heart failure patients, while we markedly improve their prognosis, still almost half the patients die or have a heart failure hospitalization within 2 years. And so the concept has come to treat earlier, perhaps treat moderate functional mitral regurgitation. And there's now data that we've generated both from registries, the expanded registry, and from the subgroups of patients in the randomized trials that truly had more moderate MR compared to severe MR, and it looks like it might work. The data look, pretty much indistinguishable to the treatment of more severe FMR. And quantitative studies have suggested that the prognostic impact of moderate FMR is not trivial. And it may be that some of those patients progress to severe FMR, or it may just be that the volume overload from the moderate FMR is also contributing to the condition of the ventricle.
So the data showed that we can prevent this progressing to severe, right? I mean, in terms of dilatation.
Well, we believe so. We certainly believe so, but we have to prove it. And so hopefully we'll be starting very soon a randomized trial in a large number of patients to prove that early treatment with transcatheter edge-to-edge repair with the mitral clip is effective in patients with truly moderate FMR.
Final comment about in terms of volume and operator expertise from invasive and non-invasive. What is the cutoff and what is the becoming like a center is comfortable doing these cases efficiently and safely?
Well, there's clearly a learning curve. Okay, and it goes on to at least 50 to 75 procedures. But the good thing is with better imaging, and the imager, we've always say the imager is as or more important than the implanting physician.
Yes.
So with really good imaging and with good mentorship and training, I think the learning curve can be surpassed, probably even less than that, again, with somebody at your side that really knows what they're doing.
Right.
The straightforward cases, which is probably 50 to 60%, are no longer that complex with, excuse me, the different variety of lengths and widths of devices that we have can be done, fairly straightforward. And we usually get now 1+ or less mitral regurgitation. We used to be happy with 2+ or less, but with better devices, better technique, better imaging, now we get 1+ or less in 85, 90% of the time.
Dr. Stone, thank you again for giving us a great overview of the guidelines, what's going on in the trial for functional MR and transcatheter therapy. Watch these videos and others on the YouTube channel. This is Chadi Alraies coming to you from SIF 2026 in Scottsdale. Dr. Stone, thanks again.
Thanks, Joe.